Bienvenue à la session scientifique du Département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session! Cette présentation sera enregistrée et disponible sur la chaîne YouTube du Département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki ekoweshkad, akonongom egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eneagizijig, enekukamegak kanadang eje odapinagig endawajin odawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
So today's grand rounds are brought to you today by the Bruyère Family Health Team. And our first speaker, we have two speakers, and our first speaker this morning is going to be Dr. Parisa Rezaiefar. She's a family physician at the Bruyère Academic Family Health Team and an assistant professor in the Department of Family Medicine as a clinical teacher. Her interests are in medical education with a particular focus on ambulatory women's health procedures and also advocacy and equity, diversity, and inclusion for underrepresented women trainees. So with that, I will hand the reins over to Parisa. All yours.
Good morning. Merci tout le monde de m'avoir invité pour partager le travail que notre équipe a accompli pendant les dernières à peu près années. On n'a aucun conflit d'intérêt à déclarer. J'aimerais remercier le département de médecine familiale pour la bourse d'innovation de 20 000, aussi qui est le département médecin familial, le Conseil médical du Canada pour la bourse de WDL Dauphiny, la Fondation Bruyère, surtout Madame Claude Chapelain, et la Faculté de génie et le Collège algonquin. Voici quelques membres de notre équipe, plutôt l'équipe de technologie, et je vois qu'il y a plein d'autres mondes qui ont contribué à ce travail, qui sont dans la foule. Merci tout le monde pour votre travail. So I'm going to switch to English. The objectives of today's presentation is to present to you the blended learning as an approach to teach ambulatory women and non-binary health procedures, with the hope that we can expand that to teaching other procedures at our department, and using the Kern's curriculum principle to walk you through elements of developing a blended learning to teach a procedural skill. So before I start, let's talk about Kern. Essentially, he's developed the principle behind developing a medical education curriculum. And his model has 6 steps that can be used simultaneously or linearly, as you can see. And it consists on identifying the general problem, doing a needs assessment targeted at your population, goals and objective, the educational strategy implementation and evaluation and feedback. So this is a dense presentation. Whenever you feel you're lost, please look for one of these round items on top of the slide so that you know where we are. But to be honest, most of the bulk of this presentation will be focused on the educational strategies that we're using. So let's give you a little bit of a background, as I don't need to argue that with you. We know that the bulk of healthcare system is provided by family physicians, given that we're 50% of physician populations, and especially in the rural areas where 20% of Canadians have access only to 2% of a specialist, we're it in terms of providing procedures that our college is requiring of us to have, of which 80 of them we need to be competent of. And women's health procedures are only 4 of these procedures. Yet we do not have established and validated tool to determine the competency of our residents upon graduation. And indeed, the 5 SUs at our licensing exam contain no procedure skills station. So are we providing the proper environment to evaluate the competence of our residents upon graduation? That is really the question. And so given that I didn't know in 2014, based on the requirement of the residency, which now has been actually updated in May 2021, I conducted my own survey at our department of 54 of our year 2 residents before graduation in June. And essentially, we focused on the procedures that we thought were important. And as you can see, the pessary fitting at that time wasn't even a mandatory skill, but currently is as of May 2021. And so we asked our nearly graduating residents whether or not they felt that they had had adequate exposure to these procedures. The yellow is their primary care preceptor, and then the gynae is presented in orange. And as you can see, while the majority felt that it had adequate exposure to pap smear, when it came to IUD insertion for contraception, endometrial biopsy to rule out endometrial cancer, or pessary, they certainly didn't feel that it had adequate exposure. And this was actually consistent with the data that we have in nationally. Unfortunately, our last data is from the 2004, but regardless, 77% of family doctors provide pap smear, and when it comes to IUD, only 35% provided, and 15% for endometrial biopsy to rule out endometrial cancer, the #1 cancer amongst women. And of course, nobody knew, neither at the time nor still today, how many family doctors provide pessary, yet it's become a mandatory skill according to the college. So given that there was no updated data, we decided to target academic family physicians and see what are the systemic barriers and knowledge and skills and attitude that they have in providing these procedures, because they are the environment in which our residents are being trained. And essentially, our survey includes these procedures, and we're asking our academic family doctors whether or not they perform pap smear, IUD, endometrial biopsy, pessary, which is for management of pelvic organ prolapse and stress incontinence that affects 50% of women in their life. And then punch biopsy of vulva, we included that because you may be surprised to know that vulva is actually a skin. And given that the punch biopsy is a mandatory skill, we decided to extend that because 20% of women do develop vulva condition in their life. And in order to manage them, a punch biopsy can distinguish inflammatory conditions from cancers and therefore expedite care instead of patients waiting for a year to see a specialist. So this is our survey, which many of you have completed. Thank you very much. The survey is coming to a closure and we're going to use the data to improve our faculty development and your environment so that we can provide better environment for our residents and graduates. And we have 3 other universities who are participating in this survey. So I hope I've convinced you that we have a problem. We have a problem that ambulatory women and non-binary health procedures are essential services that few family doctors perform. And we have a gap in our training. We have inadequate postgraduate training. And so the goal and objective of this project was to implement innovative strategies to not only teach, but assess competence of our graduates. So what is this educational strategy? Doug and I were a fan of blended learning before it was sexy. And essentially in its traditional principle, it suggested that we can combine asynchronous virtual learning with face-to-face learning to optimize learning. And there was some evidence for it before the pandemic hit. And my innovation actually is to replace the face-to-face by simulation, because we do know from the surgical and medical specialties that simulation combined with feedback and assessment improves competency. This is very solid data from our colleagues in other specialties. So let me walk you through our virtual learning experience. We use the CSUN and colleagues' strategy on improving medical education website with 4 principles at mind. The website needs to be accessible and interactive so that it overcomes geographic and data access barriers, and it is sustainable and scalable. So we wanted to make sure this is sustainable by having opportunities to generate revenue and can be extended to other procedures if we are successful. And finally, we wanted to make sure that there are solid evidence for our effectiveness of this educational strategy by showing formative and summative feedback at the individual level, but most importantly then at program level with the entrustable professional activities to ensure that we can ensure that our residents can perform without supervision these skills before graduation, and wanted to be able to really document that. So let me just show you a little bit the landing page of our website to show you how it works. So you could either enter as a learner or as an instructor, and the web page can be used on a cell phone as well. Can everybody see that? Is everybody okay? I just heard something. Anyway, so on the landing page, they know exactly what are the first steps that they have to complete. And then at 3 months and 1 year, what are the steps they have to do? So I'm just going to show you the demographic that we've built up. And essentially, we are targeting medical students, family medicine residents, physicians, nurse practitioners, both students and nurses, and OBGYNs. And again, this is because we want to make sure that we can make these available to other programs to generate a revenue for the website. And then we wanted to have an accessible and interactive website. So each module has videos that takes the resident through each step. And of course, the actual learning module, which is again interactive and walks the resident through there you go. You don't need to hear the whole module, but essentially it's an interactive module that shows them how to take the steps for this procedure. Now, most importantly, we wanted to build in the educational effectiveness measures. And of course, everybody knows that this Miller's pyramid, and we know that most educational interventions only focus on multiple choice questions to demonstrate that the resident has learned something. So that's the lowest level of learning. And some, of course, focus again on multiple choice question to demonstrate the knows how. But what's really important is to demonstrate that the resident actually can perform these procedures using OSCE and simulation the same way that the surgical specialties have shown. And last but not least, to show that the residents can perform these procedures on patients. And so that was the spirit. Now, again, before we go to showing you our measures, we wanted to first establish what is the confidence of our residents or the learner on that specific procedure. Now, you all know that a pap smear is a procedure they need to know within 3 months of their residency. So that's our standard that we measure all the other procedures against. So the first question we ask them is how many pap smears have done in the past year and how confident are they? And then we use the same level of confidence for measuring the procedure that we want to teach them, how many of them they have done and what's their level of confidence. But most importantly, we're going to ask them how committed and motivated are they in performing these procedures, and what are the barriers that they feel they have in performing these procedures before we teach them this. This is important because then we repeat this survey at 3 months and 1 year to see if we made a change in terms of their confidence and the number of these procedures that they hopefully will be performed by them. So back to the educational strategy in terms of establishing that they know their knowledge. The first thing that they're going to do is a multiple choice question. This is the blueprint, for example, for endometrial biopsy. We use the Medical Council of Canada evidence-based approach by Pugh and Abdallah on how to develop effective and evidence-based multiple choice questions. And it's composed of 10 questions that, again, they do at the onset, at the beginning of their module, and at 3 months and 10 years. And so this is to demonstrate. I do this 10 questions, and then once I submit, I get my score. I got 1 out of 10. And for every answer that I've got wrong, I will receive immediate feedback on why I got it wrong. But even more importantly, I can open the reference that was used to teach me this skill. So immediately I go to the evidence for why I got this question wrong. So not only I'm being tested, but I'm also receiving immediate feedback, which is the key to learning, of course. All right, once I'm done doing the MCQ as well as the actual module, then I want to demonstrate that I know how to perform this procedure. So the education that I've learned, can I incorporate it into
The module quiz aims to test the learner's knowledge of the subject matter
Oh.
Like the confidence.
Sorry about that. So the game-based gamification is where I use my the skills I've learned in a case-based setting. And again, to demonstrate how we develop these, we had a blueprint, and we used again Medical Council of Canada and the Royal College on how to develop a blueprint, where we put down essentially the case background and what are the knowledge that the resident needs to be demonstrating, and what are the equipments they need, and what are the baseline physiological state of the patient, and go on, so on and so forth. And out of that, we developed these decision trees that we gave to our IT team to develop these games, where the resident at each step is confronted with a question or a decision point, and depending what the answer is, they will see the results, and they play the game until the case is resolved. So again, this is for the resident to show us how they implement their learning into a case setting. And here's an example of the learning, and I'm going to turn up the video, the sound.
In case simulation test, we simulate a medical consultation where the user interacts with a virtual intelligent patient in order to successfully manage their case. Users can talk to the patient,
Hi, doctor. I have been experiencing some vaginal spotting for the last 2 months, so I want to know if this is concerning. My aunt has breast cancer.
they can also take actions and see the results of these actions immediately.
Okay, doctor, I hope it is normal.
Or after some wait time. Relevant results are stored in an electronic medical record. Users can submit their diagnosis and get feedback on their actions.
Excellent. So as you can see, again, this is a game where they incorporate the knowledge that they've learned into a case until the case is resolved. So now that
case simulation test,
now that we've completed all the virtual learning, we're going to turn our attention to the strategies for simulation, feedback, and assessment, which is the innovative part of this project. So before I go anywhere, and without offending many of my expert colleagues, let me take a minute to discuss feedback, because I'm going to be using these terms, and I think it's important for everybody to be on the same page. So there are two types of feedback: the formative feedback, where essentially the objective is to focus on improvement. It happens in low stakes situations, so kind of in situ simulation, and it's ongoing. And it wants the resident to focus on their limitations with the goal of improving their skills. On the other hand, summative feedback takes place in high stakes situations, so real OSCEs, real standardized exams and settings where they are evaluated against a norm. And we want to see that they can actually launch off to performing independently. So for example, in the licensing exam, and it's only in those settings that we could then turn the term summative feedback within a construct into an assessment. So we can't really use it unless we have a standard that we compare the summative feedback up against. Now, what are the rating instruments for technical skills that we have in family medicine? Well, let me tell you, there are no validated technical skills performance rating instruments. On the other hand, surgical specialties have really excelled at that and have developed validated tools. The first one is global rating scales, developed actually by our own Dr. Nesrick in general surgery. And it looks at the psychomotor of the resident's performance. And it's really shown the evidence in summative feedback. So as a result, it does require some raters training, and it is subject to inter-rater variability. So it has its own limitation. And then there is the procedure-specific checklist, which focuses on sequential observable steps. And as a result, it has less, requires less inter-rater variability and less training. And it's really designed to give formative feedback. You hold your instrument this way, you need to hold it that way. And as I said, we have no evidence-based validated tool for any of the ambulatory women's health procedures in family medicine. So because we have none, we try to develop our own. For the global rating scale, luckily, Rezaiefar had developed the global rate scale, which is validated. And actually, Malakarn in gynecology has used that to demonstrate its validity for hysterectomy. And so we modified that slightly to suit it to our needs for ambulatory setting. And essentially the global rating that we've developed, say for the endometrial biopsy, but it's for all other procedures, it's identical. It assesses the psychomotor of the resident in 6 domains: knowledge of the instrument, instrument handling, respect for the tissue. Remember that resident that injures the urethra as they're putting the speculum in. Economy of the movement, how many times they turn around before they can put that speculum in, and then the flow of the procedure, forward planning, and of course, use of assistant. How many times do you have to tell them to, for example, cleanse the cervix, or you forgot to do this. So that's essentially what it is, and it's a scale of 5. So for a total number of 30. So that was a global rating scale that we have developed. And given that there was no procedure-specific checklist, and different people perform these procedures differently and skip different steps, which I've heard from the residents, we decided to do a modified Delphi, and we invited expert family doctor, academic family doctors in women's health procedure and OBGYNs across 17 universities. And we recruited 16 physicians representing 9 universities and 5 provinces. And what we did, the checklist that we developed, we sent them to them anonymously through an online survey, and we asked them to rank each step on their importance. And we decided that if the majority of the people vote an item in, it stays in. If the majority of people vote it out, we're going to vote it out. And if there are items that are indeterminate, we're going to send them for a second round until we've reached consensus. We only needed 2 rounds of Delphi, and what you need to know is that we started with these number of items on our checklist, and as you can see, none was determined and unimportant enough to be removed, but some items needed to be modified. And these are the number of items for each checklist that we ended up having. Now, to validate the response rate and relationship to other variables so that we can actually convince you that they are okay to be used as formative or summative feedback, we invited some of you in October, the day after Halloween, to validate these rating instruments for us. So thank you for those who showed up and helped us. So we ask you to play at our simulation stations, and then we ask you to rate a first-year resident and a second-year resident video on performing these procedures and essentially rate them. And once they were rated, we ask you to predict if this was a PGY1 or PGY2, and then we correlated your response with their level of training. Now, as you can see, and again, predictably, the procedure-specific checklist did not correlate with the level of training of the resident. No surprise, that's what the evidence suggests. They're good for formative feedback, not summative. And again, predictably, the global rating scale was very much predictive of the level of training of the residents. Again, summative feedback, which the evidence is for. And you told us that you liked our rating instruments in terms of how they perform, how you use them, the language. And as you can see, our scale was out of 36. And for all procedures, both instruments ranked above 30. So you told us you liked them. So now you actually have an instrument to give feedback in low stakes in situ or medium stakes OSCE setting to give your residents feedback on how to perform these procedures. And you have a summative feedback tool to test these in workplace assessment where your resident is performing these procedures. And why is this important? It's important because if we're able to repeatedly capture the performance of our resident in July 1st PGY1 to July 1st PGY2 and before their graduation, then we actually have enough data set to call this a programmatic assessment and therefore generate our own entrustable professional activities that we use to tell a resident they can do this procedure independently. I'm almost done, don't worry. We're at the implementation. That's why we're here. We want to know what you want to do with this innovation. So far, in the past year, this is the first year anniversary of starting this project. We have completed all the aspects of measuring the confidence and the competence for these procedures. And the module deliveries have been completed for endometrial biopsy and IUD. We're hoping that by next year, this time, the vulva biopsy and the pessary care module are completed. And then we're looking for your feedback to discover this within our department by 2023. So the opportunities, of course, endless. Can we incorporate that into Femoral 2.0 as a to use it to capture the residents' competence? Can we use that as OSCE setting for academic health, academic day, or site-specific education and faculty development? And that is the time where the evaluation and feedback comes to play, where we send you, for example, our MCQs, and we ask you if they make sense, or we ask you to play on our games and give us feedback so that we can modify them and improve them. And many thanks to many people who have helped with this project. I can't thank enough Doug, and of course the department for the support, both human resource support and the financial support for this project. I'm going to stop my screen and open up for question and remarks.
Parisa, thank you very much. Great presentation, overview of the innovation. Certainly, you've been able to capture a lot of the technologies that we're beginning to adopt. So this is great. We've got time for a quick comment or question, and then we'll turn things over to our next speaker, Dr. Liddy.
Congratulations, Parisa. Fantastic work. You know, you have done so much, especially to do the foundation work. So my question to you is, what advice would you give to folks who are just starting out and examining their own curriculum gap or problem in family medicine that they're going to start tackling? What's your advice?
Claire, you gave me an advice many years ago when I was in these guys' shoes. You said, do your literature search. Because if you might think it's a problem, but it might be just your problem. Somebody else might have solved this problem, right? So when we wanted to develop our website, you know, doing a little literature search, led to Johns Hopkins that has actually developed these websites and very effectively is generating revenue and scaling up to other skills. So I would say the most important and undervalued step is your literature search. And then the second one is persist. Persevere. It's very hard to be innovative because you may see things that no one else sees. And it is very hard to be a disruptive or disruptor in this day and age, because you really have to have your evidence in medicine to get people's buy-in. So not only you need to be innovative, but you really need to be scholarly and engage people who know, people like Doug, people like Sue. Don't be ashamed of asking other departments, OBGYNs, DIME to help you out.
Great advice, Parisa. Well, thank you, everyone. Please feel free to use the chat. I can see David Ponk has already started off. So if you have any questions for Parisa, please put them in. It's now time for me to introduce our second speaker, and that's Dr. Shawna Hacker. She's a clinician teacher and incoming postgraduate director at the Bruyère Family Medicine Center in Ottawa. And her interests are around procedural education, including the effect of the pandemic on trainee confidence in performing minor office procedures. So Shauna, I'm going to hand things over to you now.
Thanks, Doug. I think it seems like Claire Liddy's question was, it's almost directing from Parisa right to me. So I will share here. Can everybody see? Okay. All right. So yes, I'm a family doctor at Bruyère, and I have a great passion for medical education and also procedures. And I'm going to talk about an issue that probably many of us had, starting March 2020, which is how do we ensure the proper education of our residents when everything sort of turned to a virtual world. So I'm just going to talk about kind of what the issue was and how I looked closer at that and some of the root causes that the residents came up with. And one of the interventions, which was the creation of minor office procedure videos, among some others interventions, and then look at sort of the initial feedback and where to go from there. So this is me in my natural habitat, just happy as can be, waiting to do a procedure. And, we had, I don't know if other units are similar, but there was a fairly substantial amount of time where we didn't have residents in the clinic, which is sort of crazy to think back at, but there was redeployment, there was residents were sometimes at home, sort of doing more virtual clinic. And so when we kind of advocated to get the residents back into the clinic, a lot of the appointments, and we were really one-to-one supervision at that point, a lot of the appointments were actually procedures, whether they were, endometrial biopsies like, Parisa talked about, or, skin biopsies. And that's just because at that time, if you recall, you still had to kind of justify to bring somebody in, and it's very difficult to do a punch biopsy over the phone. So these were the ones that you would say, okay, this person has to come in. But when the residents came in, it was really a shock. It was really starting from the basics again. Even from, which procedure are you going to pick? Where do I get the tray? How do I set up the tray? How do I hold my instruments? I mean, it was really there were some deer in the headlight moments. So my concern was, okay, well, how are we going to get the residents to a place where they are confident enough to keep doing this once they're in independent practice? So I started just by looking at doing a survey, just in case maybe it was just me, maybe it was my feeling. And so I got 24 of the residents from Bruyère and Primrose to write back, and just slightly over half were PGY1. And I'm giving you this is really a snippet of kind of all the data of this project. So, but one of the questions was, do you feel that the COVID-19 pandemic has affected your confidence and competence in minor office procedures? And 96% said yes, and 1 was unsure. And then another question was, are you concerned that you will not gain the competence in minor office procedures by the time you graduate? And 82% said yes. The interesting thing about this is this was in December. So this was in December of 2020, which means that the PGY2s only had about 6 months left of their residency, of which probably less than half would be in family medicine. So they would be off service. So this was a great concern to me. And so we looked at the residents offered ideas on the root causes of this. So why was their confidence low? So low volume in FM, of course, there was just fewer patients being brought in at the time. Low number of structured procedures clinics, which we run at both Bruyère and Primrose. Lack of adequate time, lack of a preceptor who was familiar enough or confident enough in the procedure to guide them through it, all the way up to things like redeployment, and the preceptor takes over because I don't know what I'm doing, or there's not enough time. And so then looking at, what did they think would help them in going forward and gain confidence? So increasing volume of procedures in FM is up there, of course. Bringing back the procedures clinics and these large group teaching sessions, both of which we did as well. And then a bunch of people mentioned this procedure videos. Now it's interesting. I mean, we've just come from this incredible presentation from Parisa of, how do we sort of bolster your understanding and confidence? And so this was one of the main things that I did to try to bridge this gap. And it came from, similar work like Parisa's of creating this educational strategy that gives us as much preparation as possible, but also back in from playing sports. So my husband jokes that I live in my glory days of when I played sports, but we had one practice a week that was visual. Okay, so we would not be on the pitch. We would go through the tactics and the plays and stuff like that. And there's really good evidence to support this, even as high up in the Olympics. So the thought is that you don't have to be in the environment actually doing it. And it's even one step removed from simulation, because simulation is really on a model or in a room or in the sim lab, stuff like that. So this is kind of even one step removed from that. So if we can get our brain going through the steps and feeling kind of confident in that way, then it allows us to make as much as possible from the actual encounter, from the actual procedure. So this is the kind of the intervention. So it started with 3 videos. The first one was a planning one. So this is really, you're looking at the patient in front of you and you're deciding, should I even cut into this person? Is this justified? To in which way am I going to take this out? Or in which way am I going to address this lesion? To let's look at their chart and look at what are the medications on their list, what are the medical conditions that may impact the procedure, what strategies do I have if I think somebody's going to be at high risk of bleeding. The second one is gathering your supplies. That's sort of just as it sounds, the use of checklists of, what types of tools you need for each procedure. Preparing your tray is, again, just as it sounds, it's sort of what do you keep on the tray and off, how do you organize it, and how do you draw up your anesthetic in a sterile way. So we have this, we use this one-handed anesthetic draw, and I'm not allowed to do a shout out. I'm doing a whisper out. Thank you to Chuck Adamson for his help with these videos. And, he's the one who taught me this technique. So, this process was informally iterative in that these videos were sent out to, medical students, nurse practitioner, physicians, to get some informal feedback. And so I was able to incorporate things that were suggested. So things like more summary slides, more time in certain areas. So one of the things that came up was this anesthetic draw that a lot of residents really want that, before they head into a procedure. So I made a fourth video. So I'm going to try, my computer has crashed before I try this, but I'm going to try to play this video. It's a very short clip of it. And if I have a backup option if it crashes.
Next up is freezing the skin. So we have here a 25 gauge 1.5 inch needle, which Chuck is putting on the syringe, and a 30 gauge 0.5 inch needle. Remember that the bevel faces up towards the pink safety cap. And we put a 30-degree bend by pushing the needle bevel up against the tray, as this gives us a better angle for injection. Grab a piece of gauze, create a little counter traction, and insert the needle fairly superficial in the area that you are going to make your cut. Remember that if you're doing a punch biopsy and putting in sutures, you'll need to freeze a slightly larger area in anticipation of this. Never inject the needle towards your finger. You can usually tell you've frozen the area well if you see blanching, if you're using epinephrine, and you raise a wheel surrounding the area of interest. Gently test the skin to make sure the patient does not feel anything and inject more freezing if they do. Once you have the skin frozen, gently place your injection needle back on your tray, tucking it into its cap without holding the cap, as the needle can go right through this plastic.
So that's just a tiny clip. So the goal of this was, if any of you have looked at videos, I think some of us, if you haven't done a procedure in a while, you may look to look for a video that will guide you. But oftentimes it's kind of in this echoey room or an emergency department, and you can't really see what is the doctor drawing up? What is that? And so it's meant to be very sort of close-up angles on everything, and just sort of as simple as possible and as clear as possible. So what we did was we played these videos at the large group intro to procedure sessions that all the PGY1s at Bruyère and Primrose come to. Interestingly, it's a lot more efficient than Chuck and I are droning on and on. So we were actually able to spend more time doing the actual procedures, practicing on the models. And so we played them and asked for feedback at the time. And the goal for this are these videos an educational tool that the residents feel is worth using in their resident education, et cetera. So for this survey, it was all PGY1s, and there were 17, so slightly more from Bruyère. And I asked the same question: do you feel that the COVID-19 pandemic has affected your confidence and competence in minor office procedures? This time, 68% said yes. So either the sample is very, very small, or it shows that the medical schools, this is now a year and a half into the pandemic. So we were getting medical students and residents more into the clinical setting. And then another of the questions, again, this is sort of a snippet of the survey, but how often have you used video resources in your medical education? So 70% said very frequently or frequently. A quarter said occasionally, and 5% said rarely. And so the survey asked a couple questions. Again, is this sort of a useful piece of material? And so, was this material presented effectively? 100% said agree or strongly agree, which is great. After watching this video, I feel more confident, which was really kind of where this all started, this sort of level of confidence. And similarly, 100% agreed or strongly agreed. And I would watch this video again to prepare. So 66% strongly agree, 28% agree, and 6% unsure. And interestingly, these are the correlated with the residents who have done surgical training, so switched from a surgical specialty. And actually, they were able to say, where would you use this? In what settings would you want to use this? And so most of the residents really checked off most of the boxes. So it was, before a procedure in my own clinic, before a large group teaching session, before an off-service procedure. So it was interesting. So that's really, that's as far as it's gone. It's just the creation of these videos and trying to get a little bit of feedback on them in terms of what direction to go. So the good thing, the nice thing is that, when I get feedback, I'm able to sort of incorporate it right into the video just because they're sort of live, as you may say. And in terms of spread, I mean, I think they're fairly basic level. So, I've had discussions with our nurse practitioner because they have, Alain has students coming in as well. And he does a lot of procedures all the way to Lena Shopoff talking about, would this be useful in the, as medical students go into clerkship. The other next step is I have really great footage from actual procedures. So these are on patients. These are live patients. There's a shave biopsy here and elliptical excision here with their consent, of course. So though the footage is there, it's just a matter of making the actual video. And so those are going to be really more concise. And, these are the steps that you use in each of these procedures. And lastly, and I think this is really interesting to come kind of after what Parisa was just talking about, but is how do we turn competence into competence? And like she said, there's really a paucity of kind of information about procedural education and competence, and how do we measure that? So I was very fortunate to go to the Telfer Quality Improvement Patient Safety Leadership course. And in my group were a couple of surgeons. And so they were quite interested in the idea behind this project. And the idea of, is there a way that you can measure not just confidence, but competence? And they talked about some of the tools that they use in Ottawa. So including this thing, I don't know if everybody here is aware, but there's something called an O score that they've developed, which is, basically in the OR, if I'm the surgeon supervising, what, scale am I going to give this resident? So from 1 to 5, 1 being I had to take the tools out of their hands and do it, to 5, I could have left the room and had a latte. Like I had no involvement in the actual procedure. So that's another interesting avenue in terms of, how can we sort of stamp off these procedures. And I know Dr. Holt she has no power, so she couldn't log in, but she's been talking for a while and working on the idea of a procedures passport. So can we sign off, I've seen this a couple of times, you've been really good to go, you've been fully competent through, X measurement. And so it kind of goes in your passport. That is it. That was the whirlwind version of what I've been working on. I welcome any questions.
Shauna, fabulous. Great presentation and overview of these innovations. Yeah, certainly 100% back this. O score, that's Wade Gofton and crew, orthopedic surgeon here in Ottawa, and this is a scale that's been developed. And this is what we find in competency-based medical education, where we've made inroads. And a lot of the studies have been on the procedure. There's lots of opportunity to look at other elements, communication, collaboration, these areas. These are sort of the inroads that we can certainly make. But great presentation. I open it up for questions, comments. Claire.
Fantastic work, Shauna, really impressive. I love the animation, sort of the art aspect of it too. So anyhow, so there's I just have a comment to let you know, and again, this is, we are doing quite a bit of work on looking at the use of games and video in medical education. So there's 2 activities that got started last year by summer students. One is a national survey, and the other one is we're just about to start the scoping review. So again, I would invite, I think I meet lots of people, there's sort of this, let's connect all the dots together. Let's use, some of the work that Parisa has done in terms of the scale development. Let's use some of the ideas. And this is, I think we do have, again, some really good foundation work. So I would invite you to do a follow-up, and then, the point of the scoping review is that, we can provide you and give you a cut of the data that would be relevant then for video, for example, So lots of activity going on. So keep going. And then open invitation for all faculty as well. You know, I think these are teams and sort of some projects that I'm sure for Shauna and for Parisa would welcome more participation from other faculty. And or, you know, being a user of the research, so participate in the surveys, be part of the group if you think your residents would, you know, like to get involved. Again, encourage follow-up and connecting things together. But this is great, and really, really nice work. High impact for what you've done. So congratulations.
Thank you.
I have one more. Can you speak a little bit about the sports application then? Have you actually looked recently, you know, at like, obviously there would be an evidence base for that. So have you started to kind of see, you know, what is the, I guess there's a theory behind it. I'm not the medical education expert, but have you looked at that, or maybe get one of your residents to?
Yeah, I think it would be an interesting project. I think that, you know, at the time that I was playing sports, we had sort of a specialist come in and talk to us about, because it was a big deal. I mean, it was a big deal to take out a practice a week, right? Or practice on the pitch. So I'd have to look at it again. I mean, this was, like I said, my glory days are a decade ago now. But yeah, and I think it carries over too. I mean, like what I did my master's in anatomy is you look at how do you teach these how do you educate in these visual 3D specialties without always being right in a cadaver? So I think that it is something that's really interesting to look at.
Thank you, Shauna. And thank you, Parisa. Okay, a couple quick comments where we've got about a minute left. So Paul, then Parisa.
Yeah, no, thanks so much. That was awesome. I just wonder if either Parisa or Shauna have any ideas about other, like I'm thinking, you know, sport medicine, injections, other areas of medicine that this could be expanded to.
I think, I don't know how much, you know, Parisa and I have spoken directly about this, but of course, you know, what she's been doing is so inspirational. I think I really have this feeling that we are, you know, on the verge of having a ton of possibilities. So we do have really incredible talent in our department. You know, we have people who do ultrasound guided injections. We have lots of, and I think, you know, McMaster does have some injection videos, but they're not, they don't have everything. And I really think that if this is clearly something that a lot of us are interested in, that it would be incredible to use all that talent once we have kind of a base and really become kind of a center for this type of, you know, education and innovation. So I do think that's quite exciting.
So yeah, so a couple of comments. So the reality is that unless we actually have a national consensus on the steps involved with what we do, and we demonstrate that it actually educate physicians who will do that, nobody will buy our product. So this is where, again, the rigorous establishment of your blueprint, because remember, this doctor doesn't use a tenaculum. Well, I'm not going to use a tenaculum, right? So you need to have a consensus that what are the important steps that need to be demonstrated to call somebody competent in IUD, for example, insertion. So the blueprint is extremely important. It's also important because virtual reality, these haptic gloves, are going to be becoming cheaper. So for us, again, to have these content being well validated and well tested, then all you need to do is you give it to the IT team and they create the virtual reality for you to play on it, to test the residents and demonstrate their competence. But really, unless we show that these residents graduate and do it, it's going to be very hard for people to accept it. And that's why, you know, we go right back to the way we do things in family medicine.
Thank you, Parisa. And thank you, Shauna. We're out of time now. Before we leave, though, please, you can see Sylvia's put in the chat evaluations. This is very important for accreditation. So please do complete these evaluations of rounds. And I can see also that Ben Robert has put a relevant article posted in the chat as well. So on that note, have a great day, everybody, and hope to see you all Rio Day later in June.